Okay, welcome to our next webinar. Today we are going to talk about Parkinson drugs, anti-Parkinson drugs, and today is December 1st, 2016. So we are going to start with our topics in pharmacology about anti-Parkinson drugs. Okay. All right, so I'm going to make a small summary of everything that we need to know for NCLEX. So we already know about Parkinson. Parkinson is a disease that is affecting the central nervous system, especially on the basal ganglia where we have the dopamine deficiency. Dopamine is what is doing in the central nervous system is to regulate and tune the muscle activity, the small movement of the muscles. Okay, so we have some causes of Parkinson. One of these is going to be, for example, head traumas, permanent head traumas. Another ones are going to be pesticides. Okay, so we have some highlights for NCLEX and talking about, for example, Parkinsonism. What is Parkinsonism? Parkinsonism is not Parkinson, but have the same signs and symptoms of Parkinson. So who is going to trigger out these signs and symptoms are going to be, for example, the metoclopramide, that is prokinetic, that is used for gastric acid. We have neuroleptics, the antipsychotics. So in psychosis, we are going to have that many of these neurotransmitters are going to be elevated, especially the dopamine. And what is doing the phenothiazine, that is actually high yield for NCLEX, is an antipsychotic that can lead into problems of extrapyramidal movements that are actually the movements that we have in the a normal movement that we have during Parkinson. So we already talked about that what is the lab test for diagnosis of Parkinson, and there is none. So Parkinson there is no lab test who make the diagnosis, are going to be basically based on the clinical findings. Okay, so we will see that there is actually the main signs and symptoms of Parkinson. So what is Parkinson? Parkinson is an imbalance between the dopamine and the acetylcholine. When the dopamine is high, the acetylcholine is low. And the opposite, when the dopamine is low, the acetylcholine is going to be high. So dopamine is going to be is going to work as inhibitor, and acetylcholine is going to work as a stimulator. So that actually produce, acetylcholine produce the muscle contraction. So excess of acetylcholine is going to lead into abnormal movements. So two things that we need to remember here is that dyskinesia. The dyskinesia, what is dyskinesia? Is the loss of voluntary movement. So it's going to be like an unstable and coordinated muscle movement of upper, lower extremities, face, and trunk. Okay, so if we continue with this, we need to have general things about Parkinson that are NCLEX related. Is what are our goals for a treatment for with anti-Parkinson medication? Number one is to minimize the signs and symptoms. So you already know that Parkinson is not curable. This Parkinson is going to be controllable, and mostly we will see that in about the medication is receiving by the patient is going to be effective in the next 8 to 10 years approximately. So after that, the medication start to lose this effectiveness. So how we are going to assess the effectiveness of the medication during this time of treatment? Number one, the goal is to minimize signs and symptoms, to increase the abilities to to eat, for example. For example, they cannot take a spoon to their mouth, so they can have some problems of malnourishment. So in general, it's going to improve the quality of life of the patient. That is how we are going to assess the effectiveness of the medication. So as I said, there is about 8 to 10 years where the medications are going to start making effect. But after that, the Parkinson medication start to lose their effectiveness. So that is what we call wearing off phenomenon. The wearing off phenomenon. What is the wearing off phenomenon? Is after years taking the medication is not going to be as effective as before. So we are going to talk about some. We have basically we have 4 type of medication or group of medications. So we have here the MAO, the monoamino oxidase inhibitor, the dopamine, levodopa, carbidopa, levodopa, and the COMT, catecholamine or methyltransferase inhibitor. So how many type of medications we have for Parkinson? We have 4. These anticholinergics are going to be added to these 4 medications when these about 8-10 years, the shaky hands, shaky body start to appear. Why? Because these medications are not as effective as before. That is the moment where we are going to use anticholinergic medication. So let's start talking about the first drug that we are going to see is the MAO, the monoamino oxidase. This MAO, there's the name that we need to remember is the selegiline, and selegiline, the commercial name is the L-Depril. So what is doing this MAO, monoamino oxidase inhibitor? So what they are doing, what is our goal in Parkinson is to increase the dopamine levels, When you increase the dopamine levels, the signs and symptoms of Parkinson's is under control. One question, how the patient of Parkinson, what is the mortality rate, or how the patients of Parkinson can have can die? And actually, mostly they don't die because of Parkinson itself. They mostly die from some accidents because of the lack of coordination of the body. They can have some accidents, or there's some percentage, about 10% of people who have Parkinson in about 10 years, they can lead into dementia. All right, so what is important about MAO inhibitors? Number 1 is about the food. So patients need to avoid food, for example, cheese and wine. They will actually produce interactions with the MAO inhibitors. So what is the interaction? It's going to lead into a crisis of hypertension, so hypertensive reaction. So they are not able, they will not be allowed to take some food like cheese or wine when you are taking MAO inhibitors. Another thing that we need to remember is that these patients need to take the medication at breakfast or lunch. Why? Because they can cause insomnia. So they are going to feel like somnolent, sleepy all day. So it's better to take it at breakfast or lunch to decrease the potential for insomnia. Selegiline is going to do what is the first line of medication is going to give is going to slow down the progression of the Parkinson's disease. Okay, so let's talk about the next drug. If COMT is not effective, we are going to add another medication that is the dopamine agonist. So the dopamine agonist, the prototype medication will be the apomorphine or the apoquine. So one of these, the main side effects of dopamine or apomorphine or apoquine is the extrapyramidal signs and symptoms. So they are going to have this what we call facial grimancy. So facial grimancy means that the expression of the face is always in pain, a facial pain expression on the face. Okay. All right. So we need to give the dopamine, especially with food, to prevent increase of gastric acidity. All right, so let's go to the one of the most common medications that are going to be used for Parkinson is the carbidopa levodopa. Carbidopa levodopa. First thing we need to remember is that the precursor to form dopamine is going to be the levodopa. Levodopa. Why they use carbidopa simultaneously? Carbidopa is similar to the levodopa, but there is part of the metabolism of the neurotransmitters that when they pass from neuron to neuron, they are going to actually diminish or metabolize part of the levodopa. So meantime, they are going to be carbidopa in order to raise the amount of levodopa. In conclusion, just to not go too deep into the mechanism of action, the levodopa carbidopa in combination, what it's going to do is to increase the levels of dopamine, increase the levels of dopamine. So one thing that we need to remember, please, here is that this medication is not going to have full effect up to 6 months. So 6 months, a continuous medication given to the patient is not going to have full effect until 6 months. 6 months. Side effects of this very common carbidopa levodopa will be palpitations, hypotension, and urinary retention. Urinary retention. Okay, so those are very high yield for NCLEX. So please, hypotension, urinary retention, heart palpitations, and nausea and vomiting. Another high yield is going to be the contraindications of carbidopa levodopa. We have melanomas, that is cancer of the skin, and close angle glaucoma, so glaucomas. So melanoma is not that is going to produce melanoma, but looks like a melanoma is going to be more invasive if that is the case. And close glaucoma, we don't use in glaucoma the carbidopa or levodopa. Okay. So we review a little bit. We talk about, first of all, the first drug is going to be used, first line is the MAO inhibitor. Second is going to add the dopamine. Third is going to be added the carbidopa levodopa. And fourth, that is the last of the 4 groups of medications for Parkinson, are the COMT inhibitors. COMT inhibitors. COMT inhibitors, the prototype name is the entacapone. Entacapone. Just remember, like the gangster Capone. So, few things about COMT inhibitor. We have entacapone may change the color of the urine to brownish to orange. And another thing, you need to remember that this guy, this gangster, have a liver disease. So what does it mean? That if you have receiving entacapone, it's contraindicated to have the medication if you have any liver disease, hepatitis or whatever, glycogen problems, etc. And they are going to change the coloration of the urine. So what is the nursing implication or nursing consideration here? Is first of all to educate the patient and tell the patient that the color of the urine is going to be brownish or orange. So the patient is aware, and you need to tell there is nothing to do, it's just the medication, and that is just temporary. So that is all about. So there is no other nursing considerations about the urine of the color of the urine in this under this medication. Another thing that we need to remember is that this entacapone is the last medication of the 4 lines that we have for Parkinson, and this is having fewer side effects than the rest of the medications. All right, so already passed about 8-10 years, and the patient is receiving every day his medications for Parkinson, And suddenly, well, progressively, the medication is not going to be as effective as before. So as you already know, that Parkinson is an imbalance between the dopamine and the acetylcholine. So when the dopamine is low, in this case, for example, the patient can raise the levels of dopamine in blood even with medication, so the dopamine is going down, is going to decrease. So because of this, the acetylcholine is going to be raised. And you know that the acetylcholine is going to be an stimulator of the nervous system. Dopamine is an inhibitor. So if the acetylcholine is elevated, you're going to have, remember, acetylcholine produce muscle contraction. So you start to have these abnormal, uncontrollable movements of your hands, etc. Okay, so for that, if the acetylcholine is going to be high, we are going to give anticholinergics. Okay, so anticholinergics. So what are the most common side effects of anticholinergics? Are going to be dryness of the mucus, blur vision. Why? Because the moisture of the in the eye, especially on front of the cornea, are lost, and that is going to lead into dry eye and blur vision. Remember, in order to go to the next chapter, you need to remember what is a cholinergic effect. Cholinergic effect is going to produce the person. Increase of cholinergic effect is going to be this shaky of the hands, normal movement of the muscles, contraction of the muscles, are going to do a lot of salivation, a lot of saliva, cholinergic, a lot of saliva. Cholinergic is going to be incontinence, fecal incontinence, urinary incontinence, and they are going to be producing in the heart is going to produce bradycardia. So that is cholinergic. So what is the effect of anticholinergic? Anticholinergic is going to be everything is dry in the body. So that is actually the conclusion about between cholinergic and anticholinergic. So cholinergic, everything is going to be moisture and wet, and the anticholinergic is going to make everything dry. So just a simple way to remember what are the side effects between cholinergic agents and anticholinergic. Okay. All right. So let's continue with cholinergic drugs. That is the transition for our next chapter. Okay, so let's start talking about the cholinergic drugs. And the cholinergic drugs, we already know what are the actions of the cholinergic medication. First of all, remember the acetylcholine. Acetylcholine is going to use cholinergic receptors. These cholinergic receptors are going to be subdivided in nicotinic and muscarinic receptors. Muscarinic and just a moment. Muscarinic and nicotinic receptor. So what are the effects of the nicotinic and muscarinic? Let me see. All right. So just a moment, please. Okay. Okay, I cannot do the other. All right, so here we have the cholinergic agents. So what are the receptors? Are the cholinergic receptors. And we are going to have two types of receptors, the nicotinic and the muscarinic. All right, so Basically, they have similar activity. What is the difference? So actually what we want to have is low doses of acetylcholine or so low doses of cholinergic effect. And when we are going to use this, remember the acetylcholine produces a contraction, right? That is going to be used, for example, when you have a urinary bladder that is not responding to the nervous system. The urinary bladder can be affected when you have a car accident. If you have a car accident, the column can be affected with the spinal nerves, and the spinal nerves are innervating the urinary bladder. So the urinary bladder do not respond to contraction. So what we are going to do is to give cholinergic agonists, and the cholinergic agonist is going to make the contraction of the urinary bladder. So this cholinergic, when you give a low dose, they are going to have mostly the muscarinic effect. Muscarinic effect. When you increase the dose of acetylcholine, that is going to affect the nicotinic receptors. So the nicotinic receptors is the one who is going to produce all these severe side effects. You know, when you give acetylcholine, produce contraction, but at the same time, it's going to make more salivation. It's going to have bradycardia. Bradycardia is going to produce bronchoconstriction, so the patient starts to have wheezing, and dryness of the. They can produce one of the contraindications for cholinergic agents is bowel obstruction. Please put 3 stars here. Bowel obstruction. Bowel obstruction. So you will say, all right, so but if I have bowel obstruction, it's good to give cholinergic agent because that is going to increase the peristalsis and that is going to resolve the obstruction. No, we don't know what is the cause of obstruction. We need to really first know what is obstruction. Why? Because if there is some mass or tumor there, you give cholinergic agents, they start to have increasing of the peristalsis, and there is no way to unblock that intestine. So what is going to happen is the perforation of the intestine or rupture of the intestine. So that's why it's contraindicated. It's contraindicated to give cholinergic agents in patient who has bowel obstruction. Okay. All right. So that is about the cholinergic effects. So let's keep going. So here we have a summary. You can see here is about the side effects of the cholinergic effect that you can review. Example, urination. Why? Because the urinary bladder is going to contract. It's cholinergic. Acetylcholine is going to contract the muscle of the urinary bladder. So we have increased the secretions, especially the lacrimation, salivation. Okay. Heart is going to be remarkable to know about the, remember always the bradycardia. Bradycardia. The lungs, important, is going to produce this bronchospasm. It's going to produce bronchospasms. So wheezing, that is what is going to happen. Okay? All right. So let's keep going to the cholinergic agonist. And we are going to have some few names that we need to be familiar with. I want to see, can you hear me? Everybody can hear me? Hello?
Yes.
Okay, thank you. All right, so we have the acetylcholine, that is, you already know the name very well, but they don't have the medication itself, as acetylcholine do not have this clinical use. Why? Because they produce systemic side effects. So that's why we don't use that much acetylcholine. So another thing that we are going to use is the beta-nicole, that is basically used for stimulate urinary and GI tract. Stimulate the urinary contraction when you have, let's put it, lazy urinary bladder because there's no innervation because some nerves are not there anymore. They are going to use the beta-nicole. Beta-nicole versus carbachol. Beta-nicole sounds familiar from carbachol. And carbachol is similar to beta-nickel, but is going to last longer. So we have the civetmethine that is used for Sjögren syndrome. Sjögren syndrome is actually when you have dry eye, for example. The eye you have urethritis, you have a dry eye, and there is a relation between the urethritis and the dry eye. But just to go directly to the point, we have the civetmethine that is used for Sjögren syndrome that stimulate the secretion of tears, tears on the eye. So the eye is going to not be dry. Another thing that be high yield for the for NCLEX is about the pilocarpine. Pilocarpine is going to be used a cholinergic agent that is going to be used for increase the secretion of the aqueous humor. Okay, so that is going to be aqueous humor is in the eye. So glaucoma is the accumulation of aqueous humor. So if you give pilocarpine, they are going to produce the excretion or release of the aqueous humor outside of the eye, decreasing the pressure inside the eye. Okay, so now there's some few things that we need to remark about the other medications. We have the myasthenia gravis. Myasthenia gravis. Myasthenia gravis, as I mentioned at the beginning, and we are going to classify, for example, Parkinson disease, central nervous system. The problem is in the central nervous system, in the brain, right? So that is Parkinson. But myasthenia gravis is in the peripheral nervous system. Peripheral nervous system. So that is a big difference. Myasthenia gravis, what it's doing is a flaccid muscles. You cannot contract muscles. So you always like muscles are relaxed all the time. And that is going to affect especially the diaphragm that can produce a respiratory arrest. So myasthenia gravis are going to be treated mostly with cholinergic agents. Okay. So if somebody, for example, we want to stimulate, we want to make a diagnosis of myasthenia gravis, you're going to use the hydrophonium. This hydrophonium is going to last a few minutes, and they are going to increase the acetylcholine, because myasthenia gravis, the problem is in the receptors where they cannot grab the acetylcholine. Receptors were in the neuromuscular junction. So if there is no that stimulation, there is no contraction. So they give you hydrophonium, and that is going to improve the contraction of the muscles, but it's going to last just a few minutes. So that is making if that is the case, we are making the diagnosis of myasthenia gravis. So people who are having problems with insecticides, what we are going to use is a physostigmine. Neostigmine is using for myasthenia gravis. Pyridostigmine is going to use for myasthenia gravis. So if you can see, most of these are going to be used for myasthenia gravis. Okay? All right, so just be familiar with the names. Pyridostigmine, neostigmine, physostigmine, hydrophonium, and you already know what are side effects or what are the effects of the cholinergic receptors, and the anticholinergic is going to be the opposite of the cholinergics. All right, so give me a second. We are going to change gears here. Okay, so now we will talk about the biological response modifying and anti-rheumatic drugs, and for that we are going to go straight to what is really relevant, important in this review. We are going to see that these drugs are going to, we call in general, biologic response modifying and anti-rheumatic drugs. So for this, we are going to see this chart. So we have two main groups. We have the hematopoietic drugs and the immunomodulating drugs. Okay, so let's simplify this. Biologic response modifying drugs, they can be called cytokines. Cyto means cell, kines is activity. So these substances of these products are, these substances are going to make the cells have some activity. That's what it means, cytokines. So these cytokines are going to divide it in hematopoietic drugs and immunomodulating drugs. So I will say something here. For example, the hematopoietic drugs, we have, they are going to stimulate the hematopoiesis. Hematopoiesis, if you remember, is the production of three lines of cells. We have here the red blood cells, we have the white cells, and the platelets. So hematopoiesis. When you are going to talk about the production of only just the red blood cells, it's called the erythropoiesis. Erythropoiesis. All right. So this immunomodulating drugs are going to modify the activity of the immune system. For example, the DMARDs that we have for arthritis are going to diminish the activity of the inflammation process in the body to prevent more damage of the cartilage of the arthritis in the patient. And the other group of immunomodulating are the ones who make the cell is protected against the attack of some viruses. We are going to see that in the next slide. So let's start the cytokines or biological response modifying divided into groups. The first group, hematopoietic, and we have the red blood cells, we have the white cells, and we have the platelets. So the name to produce the red blood cells is called the erythropoietic drugs that is going to use the erythropoietin. Erythropoietin. Red is going to stimulate just the red blood cells. And this is under the hematopoiesis. Hematopoiesis includes the three lines, but erythropoiesis only just the red blood cells. So this is being used for example, athletes. Athletes are using that. Why? Because if they have the erythropoietin, by the way, normally in the body, who produces the erythropoietin? The one who produces erythropoietin in the body is the kidney. So the kidney is the one who produces the erythropoietin. So erythropoietin, then they go to the red bone marrow, and in the red bone marrow, the erythropoietin stimulates the erythropoiesis. Okay, erythropoiesis. They can be used for athletes, as you can tell. Why? Because they have more number of red blood cells who are going to capture more number of molecules of oxygen. So they can actually perform better if they have this medication. But other group that is important to know is those patients who are having cancer. And more than that, they're having chemotherapy or radiotherapy. The chemotherapy and radiotherapy, as you can tell, cancer cells reproduce very fast. Cancer cells reproduce very fast. So this chemotherapy are going to be made in order to destroy cells who multiply very fast. Okay, so cancer cells multiply very fast, chemotherapy kills the bad cells, the cancer cells. But we have in the body other cells that multiply very fast too. And who are those? Are the red blood cells. So how fast? You can tell we can reproduce red blood cells in 1 second, 2 million of them. So those cells that are reproducing fast are going to be affected by the chemotherapy, And when that happens, the red blood cells going down and the patients with chemotherapy become anemic. So that's why we are going to provide the erythropoietic drugs. Epoetin, called EPO sometimes, or darbepoetin are going to be used in order to increase the levels of red blood cells. All right, so for this, we are going to continue with the white cells. The prototype is the filgrastim, filgrastim is going to be used to increase all the lines of white cells. And we have the operobekin. So you need to be familiar with this name, that is going to increase the levels of platelets. All right, so to make it summarize about this, what is need to be remarked are the side effects of all these medications as a group. So the hematopoietic drugs are going to lead into, if you see here, headache. Hematopoietic is HE, headache. So they are going to have, one of the side effects is headache, nauseous, vomiting, and edema. Nauseous, vomiting, and edema, and headache. Okay? All right, so we have, and those are the most remarkable and the most common side effects of the hematopoietic drugs. So one more consideration about this is that that is going to be given in the 24 hours after the chemotherapy. So after 24 hours of the chemotherapy, you start to give any of the drugs according what is the indication. Okay, so let's keep moving to the biological response modifying drugs. The cytokines is the same to say this. Cytokines is shorter and easier. We already talked about the hematopoietic drugs. Now we are going to talk about the immunomodulating drugs. And the immunomodulating drugs, we have the interferon, we have the interleukin, we have the monoclonal antibodies, and the DMARDs that we are going to see at the end. So let's focus in these three first. We have the interferon, we have interleukin. Interferon, if you see the name looks like it's telling you that it's interfering with something. And interleukins means inter is in between leukins, in between the white cells. So this is a communication between the white cells, and this is actually a direct communication to the cells, to all the cells or tissues of the body. Okay, so if you see these interleukins, interferon are going to be used for some cancers or some viruses. For example, interferon is going to be hepatitis, genital warts, that is the herpes virus type 2. So we have here the interleukins. Interleukins is called lymphokines, but they are going to use for cancers, renal cell carcinoma, metastasis, melanoma, and lymphomas, and sarcoma. So if you see here, these interleukins are going to communicate between cells how to protect themselves against this invasion of or proliferation of these malignant cells, for example. And interferon is going to make the cell protect himself in order to prevent the entry of these viruses into the cells. All right, so what is important about interleukins and interferon is that they have something in common, and that is what is remarkable for this slide, is that they have flu-like symptoms. So both of them, who is having more moderate to severe flu-like symptoms is the interferon, So, but both are going to have the flu-like symptoms. So then we have, this is we need to have a pre-medication of the patient with acetaminophen. One of the side effects that you need to remark, and I will like to change color here, is the fatigue. Interferon produce fatigue, flu-like symptoms and fatigue. So those are the most remarkable things for side effects of interferon. And we have the interleukins. Interleukins is going to have some two of the flu-like symptoms, and they are going to have one important side effect, that is the capillary leak syndrome. Capillary leak syndrome. So 3 stars for here, please. Capillary leak syndrome, edema, that is that there is fluid leaking from the capillaries. So they are going to produce edema, accumulation of fluid in the tissue. Tell me one thing, what happens if this fluid, you think about the lower extremities, but not only that, they are going to appear, or they are going to accumulate, for example, in the lungs. And when that happens, we are in troubles. Why? Because they are going to decrease the gas exchange. So you have respiratory distress. Okay, so just remember interleukins, capillary leak syndrome. So capillary, at the level of the capillary, is going to leak what? Fluid. Okay, so let's finish with these three components with the MAPS. MAPS is the monoclonal antibodies, and you know what is an antibody. Antibody is going to be markers that are going to step on the bacteria, or step on viruses, or step on in some malignant cells. So what is important about this is those, as I said, those are markers. So they are not actually killing the stranger. What they are doing is to step on the stranger, and they are going to make like red flag, in order to the immune system recognize which are the targets that we need to kill. So that's are actually the antibodies. And we are going to give monoclonal antibodies, so because they are going to take some specific antibody for a specific virus or specific cell, neoplastic cell, and they are going to produce clones. So that's why it's called monoclonal antibodies. And they are reproduced in huge amounts. And that is going to be injected to the patient and produce the destruction of the, they are flagging or marking the cells that are making us problems, and the immune system later is going just to destroy them. So what is the benefit of MAPS? Is that this, what I remark here, monoclonal antibodies target certain tumor cells and bypass normal cells. So they are not going to destroy the normal cells. All right, so here we are going to finish with the DMARDs, and the DMARDs are actually used for rheumatoid arthritis. All right, so we will talk in class when you have, if you have questions about that, because not every articular pain is rheumatoid arthritis. So we will talk about another time. So what is doing the DMARDs? First of all, we need to know what is arthritis. Simple. Arthritis is, number one, anti-immune system. So it's autoimmune system, sorry. It's an autoimmune system. The autoimmune disease. This autoimmune disease means that the cells of the articulations or joints become strangers to the body. So somehow the lymphocytes are going to lose the memory, and they are going to not recognize as your own cells, so become as your enemy. And the immune system is going to actually take over and try to destroy this tissue. So what is doing the DMARDs? The DMARDs are the drug-modifying anti-rheumatic drugs, and as you can see, arthritis, the first level is NSAIDs. So it can be aspirin, they can be, for example, ibuprofen. They go, if that is not effective, they are going to go up to corticoids. If there's not enough, they are going to give methotrexate, and then at the end, that is going to be the last line of medication that we have to be able to treat arthritis is the, or are the DMARDs. What is doing the DMARDs is to inhibit the T cells. So there is a classification of T cells that we already know about that, but just remember the DMARDs are going to inhibit the T cells. So again, what are the, if you see the big picture here, so the DMARDs is going to inhibit the T cells, so that means that it's going to decrease the inflammatory process of the inflammatory process and destruction of the joints, right? But at the same time, through the inhibition of the T cells, you are depressing the immune system. So these patients can lead into have high risk for infections. Okay, so that is the double blade side of the medication. So they are going to have high risk for infections. All right, so side effects of the DMARDs. Side effects of the DMARDs are going to be flu-like symptoms. Sounds familiar, right? And they are going to be nephrotoxic. So nephrotoxic means that they can lead into kidney failure. So they need to take a lot of fluid. Another common side effect is the skin reaction. The skin reaction, you will see that the patient become the face become red, especially the cheeks are going to be very red, and that is one of the side effects of this medication. So the DMARDs, how long is going to take effect is about a month. 1 month is going to take actually time in order to make full effect. Okay, so I think that is about for this. We are going to do women health in the next class tomorrow. I guess that is about. If there's any questions, please, can you let me know? Hello? Somebody's there?
Thank you, Dr. G.
Who is this?
It's Jasmine.
Oh, hi. Let me see.
I said thank you.
Okay. Thank you. All right, so I need to thank you to, just a moment. All right, David, thank you so much for coming. Any question?
Thanks, Dr. G. No,
Okay.
no questions.
Cassandra, thank you for coming. Any question?
No, no questions.
Maria, thank you for coming, Cassandra. Maria?
No questions. Thank you.
All right.
I'm here.
Thank you, Maria.
Bye.
Monica, any question? Monica? Jasmine?
Yes, Dr. G.
All right, thank you so much. So that's all for the webinar tonight. I'm going to post the webinar and I'm going to download it and put it in the, I'm going to send you a link in your email so you will find it so you can watch it at any time. Thank you so much. I will see you tomorrow. Gracias.
Thank you.
See you later.
See you later.